the liver causing hepatitis, and the cervical lymph nodes causing lymphadenitis in the neck, also known as scrofula. Testing for TB often starts with a purified protein derivative, or PPD intradermal skin test, sometimes known as a tuberculin skin test, MAN2 test, or simply TB test. With this test, tuberculin is injected between layers of the dermis. Tuberculin is a component of the bacteria, and if a person has previously been exposed to TB, the immune system reacts to the tuberculin and produces a small, localized reaction within 48 to 72 hours. If the reaction creates a large enough area of induration, rather than just redness, it's considered to be a positive test. Positive tuberculin tests simply mean that the patient's been exposed at some point to TB. It does not differentiate between active and latent disease. As an alternative to tuberculin skin tests, there are also interferon gamma release assays, or IGRAs, which look for evidence in the blood of previous exposure to TB proteins. Since this one's a blood test, you do not need to show up again to have the test read like you do with a PPD. Also, the IGRA is more specific to TB rather than other types of mycobacterial infections, and is unlikely to be positive as a result of having BCG vaccine in the past, a vaccine that protects against TB. And this is a pretty useful feature of IGRAs, since BCG vaccine is given to many children around the world to prevent disseminated TB. After doing a screen test with PPD or IGRA, anyone with a positive result typically gets a chest x-ray to look for signs of active TB disease. In patients with symptoms like fevers, night sweats, weight loss, and coughing up blood, or hemoptysis, it's important to collect samples from either the sputum or via bronchoalveolar lavage, which is where the bronchoscope is inserted through the mouth or nose into the lungs. Fluid is squirted, and then the fluid is collected. These samples can get sent to the lab for staining, culture, and PCR to look for evidence of Mycobacterium tuberculosis. Treatment of latent TB infection typically involves using a single drug for a prolonged period of time. The most common approach is isoniazid for 9 months. Treatment of active TB disease is typically done with different combinations of anti-TB antibiotics like isoniazid, rifampin, ethambutol, and pyrazinamide, which results in patients being non-infectious to others usually within a few weeks. Until that point, though, patients can spread TB to others, and it's typically adults with reactivated TB that are the most infectious. As a result, patients are typically kept in negative pressure rooms, and visitors are asked to wear protective N95 masks that can't filter out oil aerosols, N for not resistant to oil, but can filter out at least 95% of other aerosols, in this case TB. Even after patients are no longer contagious, they're typically kept on multiple medications for many months to be sure the bacteria are destroyed, usually with direct observed therapy, or DOT, where somebody watches and confirms that you're taking the medication. Additionally, there's an enormous worry about new drug-resistant strains of TB that are causing infections in various parts of the world. You might hear of MDR-TB, or multi-drug-resistant TB, or even XDR-TB, which is extremely drug-resistant TB, which is incredibly hard to treat because they don't die in the presence of our usual antibiotics. The bottom line is to get an effective treatment. It's super important to make sure that the drugs being used will work against the specific strain of TB, that multiple medications are used together to prevent drug resistance from developing, and that medications are used for the entire course of therapy so that all of the Mycobacterium tuberculosis is killed off. Recently, the US Food and Drug Administration has approved a breakthrough medication for XDR-TB called pretomanid. According to recent studies, a combination of pretomanid, bedaquiline, and linezolid has been effective for almost 90% of XDR-TB cases. As an added bonus, this combination therapy can be taken orally, and is also very well tolerated compared with other XDR-TB drug regimens. Alright, as a quick recap, tuberculosis, or TB, is an infection caused by Mycobacterium tuberculosis that mainly affects the lungs. 3 weeks after the primary infection, the immune system tries to contain the infection created by a granuloma, and the tissue in the middle undergoes caseous necrosis, resulting in an area called a Gone focus. TB also extends to nearby hilar lymph nodes, causing caseous necrosis there as well. The Gone focus plus the affected lymph node makes up the characteristic Gone complex. If the immune system becomes compromised, like with AIDS or older age, the Gone focus can reactivate, and the infection can spread to one or both upper lobes of the lungs, where it forms cavities. From cavities, bacteria can disseminate to other parts of the lungs, causing bronchopneumonia. But it can also spread through the vascular system and infect almost every tissue in the body, which is called systemic miliary TB. Testing for TB starts with a PPD intradermal skin test, or with an IGRA blood test, and a chest x-ray can identify signs of active TB disease. In patients with fevers, night sweats, weight loss, and hemoptysis, a sputum sample can be stained, cultured, and PCR can be done to look for Mycobacterium tuberculosis. Treatment of active TB includes a combination of antibiotics, given for several months, and special regimens are used for MDR-TB and XDR-TB. Thanks for watching. If you're interested in a deeper dive on this topic, take a look at osmosis.org, where we have flashcards, questions, and other awesome tools to help you learn medicine. Otherwise, you can always support us by donating on Patreon, subscribing to our channel, or following us on social media.